trauma is now recognized as its own distinct disease pathology. And I mentioned earlier that that is a worldwide phenomenon that started right here in Lincoln, Nebraska. Brain and spinal cord injuries are definitely the most tragic and really the two injuries, body systems that get injured with the most morbidity and mortality, brain and spinal cord injury. I think Madonna here in Lincoln is just an amazing place because they specialize in just this patient right here, your brain and spinal cord injury. They do an amazing job over there. But TBI, traumatic brain injury, sudden physical damage to the brain. It could be closed injury, it could be penetrating injury. A concussion is an example of a traumatic brain injury. And that wasn't always the case. It's only been recently we started recognizing a concussion as a bad thing. I played high school football in the early 90s, and at that time, concussions, man, that was bragging rights. We bragged about our concussion. If you've ever hit your head hard enough to see stars, you have damaged part of your brain. If you've ever gotten anxious or depressed in your lifetime, I would encourage you to think about when in your lifetime did you get a TBI? Because it happens to everybody so often, especially sports, contact sports in high school, football, notorious for that. But volleyball players, soccer players suffer TBI from the force of the soccer hitting their head. Traumatic brain injury, it has ramifications for the functioning of your brain the rest of your life. TBI. And we're just starting to recognize that, starting to think about that. I used to think I wanted my boys to play high school football. I thought, yeah, it'd be great. It's a great, get you in shape, toughen you up. But neither one of my high schoolers have shown an interest in football, and I'm very happy that they haven't. TBI. If you've ever heard a story of a high school kid who killed himself in a small town in Nebraska, look and see if he was a high school football player, because it's a story that has happened in every small town in this state, and very often it's an unrecognized traumatic brain injury, something we have to talk about. As nurses, we have a moral obligation to talk about TBIs. And high school football is one example, but car accidents is a huge example. ATV and motorcycle accidents, huge example. Traumatic brain injury. Spinal cord injury is a bit of a different deal because that's definitely recognizable, and we've been talking about that because one minute you're fine and the next you're paralyzed. And so spinal cord injury has always been recognized, but TBI, a lot of times you don't see any outward signs and symptoms. A type of TBI that we see in our homeless veterans are guys that went over to Iraq or Afghanistan. It is a traumatic brain injury caused by a blast wave. So what in World War II we called shell shock, and then in the Vietnam War era we called it post-traumatic stress disorder. And we still call it PTSD a lot, but with those veterans, we have to be thinking about the traumatic brain injury from the blast wave itself. I had a buddy in grad school, he was a nurse, and we were working on our master's of science in nursing together, and we had to give a speech. And I always get nervous before I have to give a speech, and he was really nervous too. And then after the speech, I turned to him to give him a high five. We got through it. We did amazing. And he asked me, he said, "Did I stutter while we were giving our speech? Did I stutter?" I'm like, "What? No, you didn't stutter. It was smooth as butter. Everything was great." I said, why do you have a stuttering problem?" He said, "No, I served in Iraq and I had 6 traumatic brain injuries. And they're starting to recognize that what had happened to him, he was in a convoy in a Hummer, and the Humvee in front of his hit a roadside bomb, exploded. His buddies were killed instantly. And a psychiatrist would say, "Oh, yeah, that makes sense. It's post-traumatic stress disorder." Now the military is doing a much better job at saying it is PTSD. He definitely has some trauma from that, but it's also a blast injury. The shockwave from the explosion scrambled his brain. And he said that happened to him 6 different times. And when he got back from his tour, he could hardly speak at all. And he spent about 10 years on high dose medications to deal with his TBI, his post-traumatic nightmares, things like that. But it was just a brain injury. I think is an amazing story because he got himself through graduate school and is now doing great. TBI. One of the vital signs related to the brain and a trauma patient is the intracranial pressure. The intracranial pressure, and that's the pressure inside the skull. And you're asking to yourself, you're thinking, how do we measure pressure inside of someone's skull? The way that we measure this, it's not a function. Nurses don't do the procedure. We have to get a neurosurgeon on board. The neurosurgeon will place a bolt. They call it a bolt. And what they do is they just drill a hole in the skull and feed a little wire in there, a tubing that is called a transducer, and it can measure the pressure inside the skull. And so as the nurse, this would be an ICU patient. We can monitor the ICP using the ICP monitor bolt. And one of the things we can do in the ICU is a lot of times they attach a little spigot, like a water faucet, right to that bolt, and we can drain cerebral spinal fluid if the pressure inside the skull gets too high. But the normal ICP is 5 to 15 millimeters of mercury. So it's not very high pressure. If you think about what a normal blood pressure is, normal blood pressure is like 120/70. So the intracranial pressure, 5 to 15, not very high, but it can increase with a change in the volume of one of the contents of your skull. There's really only 3 things inside your head. There's 3 items inside your skull. If your skull was a box, we could say that it has three things in there. It has brain tissue. It has blood. We have arteries and veins in there. And it has cerebral spinal fluid. So we only have three things inside the skull: blood, brain, and CSF. If any of those increase in size, if you start bleeding inside your brain, for example, the pressure inside your skull increases, and that's called an increased intracranial pressure. If one of those items swells, like your brain cells, maybe they start swelling, we call that cerebral edema, or maybe you're bleeding inside your brain and you have a subarachnoid or subdural bleed, one of those other components will have to decrease in volume. And the first thing to decrease in volume is the cerebral spinal fluid. Remember, I mentioned earlier that the CSF in your brain communicates with your spinal cord. So if you have bleeding in your brain, the pressure's building, the CSF is actually going to squirt down into your spinal column to help alleviate that pressure. Anyway, the act of that happening, the change in the volume of one of the three components, is called the Monro-Kelly hypothesis. Monro-Kelly just said we've got three things in your skull, and they're in a fixed ratio. And if one of those increases, the intracranial pressure goes up. For the most part, we don't have patients with an increased ICP after a TBI. Most TBIs, like a concussion, they don't increase intracranial pressure. If a patient's ICP is going up, though, they are now officially a critically ill patient, and they need to be in an ICU somewhere. So this is just kind of a picture trying to demonstrate that Monro-Kelly hypothesis. Here on the left, we've got blood. There's arterial blood, there's venous blood. You got blood, brain, CSF. In this second picture, it says mass, a mass. A good example of that would be a big old brain cancer tumor. You got a big old tumor sitting in there. That's a mass in your skull. Your CSF is going to decrease. The CSF decreases first. That's the first compensatory mechanism. We squirt that CSF down into our spinal cord. Once we squirt a lot of that CSF down, we start squirting some of that venous blood down, and now we're decompensated and the intracranial pressure starts elevating. Normal is 5 to 15, and now we might have a ICP of 20, maybe 25, maybe 30. Signs of increasing intracranial pressure: decreased level of consciousness. That's the absolute best sign and symptom for you to assess. Remember earlier I mentioned with your neuro exam, the best thing, the most information is going to simply be from asking your patient how he's doing. How are you doing? And you will immediately know if he has a decreased level of consciousness. Maybe he was wide awake 15 minutes ago, and now difficult to even wake him up. That's the best predictor of increased intracranial pressure. Headache, vomiting. We teach people to watch for those things after a concussion, headache and vomiting. Pupil dilation is a very late sign. We teach that in nursing school. You will do a checkoff where you have to use the pin light to shine a light in people's pupils. But that's a very late sign. If you have a patient with one pupil that's huge, they are FTD. They're officially FTD, which stands for fixin' to die. They are fixin' to die. So if you're in a nursing home and you're checking pupils, we do that all the time in nursing homes after somebody falls. Part of the neuro check, checking pupils. Why are we really checking pupils? Because we want to know if they're fixing to die. If your pupil dilates and you are not in a building that has a neurosurgeon in the building, you're dead. This is a stat emergency, a run, don't walk. If there's not a neurosurgeon in the building, you better put your things in order. Fill out that living will document you've been meaning to do. Pupil dilation, very late sign. Decreased level consciousness is the best sign to assess because it's an early and it's really the best predictor. You will see test questions on Cushing's triad throughout nursing school. So do make a note of this. High blood pressure, slow heart rate, abnormal respiratory pattern, Cushing's triad, a sign of increasing intracranial pressure. You will never see this in your whole life. And if you do, that patient will die shortly thereafter. But for some reason, nursing educators feel the need to preach it all the time. Cushing's triad, high blood pressure, bradycardia, abnormal respiratory pattern. But the best predictor and the thing you should be assessing, level of consciousness. That's the real thing that we assess. And the nice thing about that is you don't need any tools. You don't need any special equipment. You don't even need to go in the patient's room. You can stand outside the door and say, "Hey, Bob, how are you doing?" If he does not answer, that's the best predictor that you've got a problem. I think Cushing's triad is interesting, but you'll never see it in real life. I've seen it once or twice. But decreased level of consciousness, we see that all the time. Headache, vomiting, also very common. This is what it looks like inside your skull when that pressure starts to rise. When the pressure starts to rise and all of the cerebral spinal fluid has squirted out of your skull, eventually brain tissue is going to squirt out of your skull. That's what herniation means. Brain tissue that's going to move down. It's only got one place to go. You've only got one hole in your skull. Clear at the base of your skull is the foramen magnum. The foramen magnum. And as your brain starts to shift and starts to move downward, we call that herniation. It's when a patient is herniating that you see the pupils change. This patient needs to be on the table in surgery with a brain doctor cutting a hole in their skull. What they do is called a bone flap. And they just cut a big chunk of the bone out to relieve that pressure. Those neurosurgeons, they do think they're God's gift to mankind. I have to say, I just love our neurosurgeon. He's a very humble, kind man, but I still like to make fun of him because those dudes, they make like millions of dollars per year. And one of the things they do is a bone flap. Cut a hole in the skull to relieve the pressure, to decrease the intracranial pressure. How long have we been doing bone flaps, you ask? This crazy new technological marvel that it is? Well, evidence from archaeological digs showed that we've been doing bone flaps for at least the last 30,000 years. Back in the day, they called it trephination. Trephination. And you dig somebody up from a grave, 30,000 years old mummy, and he's got a hole in his skull. Why did they do that? We think they were doing it to release evil spirits, maybe, but what they were actually doing is decreasing the increased intracranial pressure. Today we call it a bone flap. Back then they called it trephination. So what is level of consciousness? This is the most important thing to be assessing. It's really the self-awareness and reaction to the environment. The contents of consciousness are telling us how well your cerebral cortex is working. Do you know where you are today? How oriented are you to person, place, and time? Some of the words we use is, and this is what EPIC uses, the EPIC charting that you will do at the hospitals. They use the word alert, the highest level of consciousness. Lethargic, the lethargic person is sleepy, but we can wake them up. The obtunded person, obtunded, that's a word that EPIC uses as a default. Obtunded is difficult to arouse with little or no interaction with the environment. Obtunded, though, is better than a coma. A true full-blown coma is this person is completely out and they are not responsive to painful stimuli or voice. It's the lowest level of consciousness, a true coma. The person with a brain injury who is in a coma, we now have to do a workup to see if their brain is even alive. And we do different tests to check for brain death. If the top part of your brain is dead, but your brain stem is still alive, you are a great candidate for organ donation. Organ donation. A couple of unique mechanisms of injury. If you ever see the abbreviation MOI, that's mechanism of injury. Traumatic brain injury, MOI, includes blunt trauma. That could be a baseball bat to the head. And acceleration, deceleration injury. The head stops moving, but the brain continues to move forward. And a classic example of that is the coup contra coup injury. That's when the brain strikes one side of the skull, rebounds, and strikes the other side. A common example of a coup contra coup, somebody hits the dashboard with their forehead and they have a bleed in the front of their brain, but when we scan their brain, they also have a bleed in the back. We're like, wait a minute, they didn't hit the back of their head. That doesn't make any sense. It's a coup contra coup injury. Pedestrian versus car, also classic coup contra coup injury. The head hits the hood of the car, and then often the head hits the pavement also. It's slightly different, but you get often a bleed in the front and a bleed in the back. Coup contra coup. Penetrating injury is when you actually have a bullet or something go right through the skull. And then blast injury, I mentioned with our veterans returning home from Iraq. This example of the coup contra coup injury. And we see that in bad car accidents with kids and stuff like that. But probably the one patient that we see this the most, we see this all the time, every day, is your alcoholic. That guy that drinks alcohol every single day. Because alcohol shrinks your brain. It's a potent brain shrinker. The alcohol makes your brain smaller. A smaller brain tends to rattle around inside your skull. So the alcoholic always coup contra coup injury and gets interesting brain bleeds. Very common cause of death in the alcoholic, partly because they fall all the time. So they can have what seems like a minor trauma. They just ground level fall, boop, get a coup contra coup injury because the brain is rattling around in there. Couple of interesting maths we can do. We can do some math on the brain. And the place you would do this is in the trauma ICU. So here in Lincoln, this patient would be Brian West on second floor. And that's a patient who he's at Brian West because he needs a neurosurgeon. I'm honestly not sure if there are any neurosurgeons west of Lincoln right now. Anybody from Kearney or North Platte? When I was an ER nurse, Grand Island lost their one neurosurgeon, and then Kearney lost their one neurosurgeon. And so this patient laying in the ICU at Brian West could have come from anywhere in the state. And there's, of course, neurosurgeons out in Omaha. But a neurosurgeon is required to put the bolt in. And the bolt is how we measure intracranial pressure. And then what we do is we do some math. I took care of a patient with a bolt in the Kearney ICU. I was teaching mental health, but that summer in Grand Island, and that summer I thought, I should go work in the ICU. And so they gave me a patient who had paranoid schizophrenia because I was the psych instructor. And what had happened is we think his voices told him he had stopped at a train crossing and the rails were down and the train was flying by at 60 miles per hour. We think his voices told him to accelerate because he suddenly romped on the gas. His pickup truck implanted itself. It kind of jumped and implanted in the side of the train and then rolled down the track. The pickup truck rolled almost a full mile because that's how long it takes those trains to stop. The patient was lucky. He was thrown out just before the pickup truck exploded, but he has a traumatic brain injury. The neurosurgeon put a bolt in so we could measure intracranial pressure. And then he wrote orders. The surgeon wrote orders for the nurse to give whatever med it took. And there was dozens of meds on the list, give whatever medication it takes to keep the cerebral perfusion pressure within a very narrow range. And the way that we do the math is we take the mean arterial pressure and then subtract the ICP. And that's called cerebral perfusion pressure. Normal CPP is between 50 to 150. Of all the numbers to memorize, though, I would memorize normal ICP. Back on that slide, I think the book said 5 to 15. Well, I don't want to go that far back. That is a fun patient for an ICU nurse, though, to take care of because of how much autonomy you have as the nurse. The doctor just gives you any meds you want, and you get to go in there and squirt away, titrate drips. That patient had 18 different IV pumps running, 18 different medications. Each one has a potential impact on one of those numbers, either the MAP or the intracranial pressure. Cerebral edema can increase intracranial pressure. And the way we decrease intracranial pressure is we can drain cerebral spinal fluid with the catheter. That's called a bolt. We can bring the blood pressure down. We can try hypertonic IV solution. An example would be 3% normal saline, 3% normal saline, hypertonic. We can hyperventilate people. It doesn't work very well, and we try not to do this. But a last case scenario, last ditch effort, we can hyperventilate the patient because they are on a ventilator at this point in time, and we can just turn up the rate. You can try this at home if you would like. See how low you can get your carbon dioxide. You can drop your own CO2 by breathing as fast and deep as you can. Hyperventilation. Drop that CO2, and what that does is it vasoconstricts the cerebral arteries. Carbon dioxide is a potent vasodilator. So when we drop it, get it really low, it vasoconstricts cerebral arteries. That one phenomenon is something that's kind of a big deal in healthcare. Have you ever had a loved one, maybe your grandma, who had a routine surgery, like a hip surgery, just a routine surgery, but she was never the same mentally after the surgery? Or maybe a patient from the nursing home went for a routine surgery, but never quite woke up after surgery. One of the potential reasons for that is somebody got too carried away with how fast they were bagging that elderly person. When we're bagging somebody, we're breathing for them with an ambu bag. And this is the job of the CRNA or the anesthesiologist. If you hyperventilate that person on accident because you're checking Facebook while you're doing it, it happens. You're checking Facebook, something interesting is occurring, so you're scrolling down. You're breathing 40, 50 times a minute, squeezing that ambu bag. Happens in code situations all the time. That is dropping the carbon dioxide from the bloodstream, which causes potent vasoconstriction and can kill off part of that person's brain. But sometimes we do it on purpose as a last-ditch effort to decrease ICP while we're waiting for the neurosurgeon to walk in the room. The decompressive craniectomy is what I was talking about with the bone flap. And they've been doing that for 30,000 years, humans have. This is an example of the craniectomy. Just chop out a piece of that brain or that skull. We usually don't chop out part of the brain. It does mention that on the slide, the lobectomy. Worst case scenario, we will do that, but craniectomy, chop out a piece of the skull, let the brain swell, and then sometime later, maybe 6 weeks, 6 months later, they'll put it back. Some of your older guys will tell you they have a metal piece in their brain, a piece of metal. We try to use their own bone, though, now we replace it. Brain death is the irreversible end of brain activity, the coma, absence of brainstem reflexes, apnea. The people at the hospital at Bryan who check for brain death initially are actually the respiratory therapists. RT, Jill Sand is our health sciences dean. She is a respiratory therapist and worked at Bryan, but they actually have a policy for the RT to essentially turn the ventilator off. And they do an assessment to see if there's any response at all, or whether this patient is brain dead. At that point, we call NORS, which is the Nebraska Organ Retrieval Service. The brain herniation, I mentioned the foramen magnum. That's that hole at the base of your skull. There is also what we call a transtentorial notch. It's on this back slide, transtentorial. That's just like a shelf inside your brain, the shelf, and you can herniate past that shelf. And as it turns out, your cranial nerve number 3 runs right through there. The nerve, the cranial nerve that's responsible for dilating your pupil. As the brain squishes that, you might get one pupil that's completely dilated, and then pretty soon the second pupil will become dilated as well. The Glasgow Coma Scale, we still use this all the time and assesses the severity of brain injury. Rates 3 areas: eye-opening, verbal response, motor response. I'm not a huge fan of Glasgow because it just kind of cracks me up, because the lowest you can score is a 3. And so if you have a patient who has been dead for a week, maybe we found this person out back in the alley by the dumpster, paramedics bring them in, rigor mortis has set in, starting to smell bad, and you do your Glasgow Coma Scale, that person will still score a 3. But 3 and a dead person are the exact same thing. Highest is a 15. For the most part, if you stick your head in the door of the patient's room, "Bob, how you doing?" Bob says, "I'm fine," and waves. He scored a 15. He just scored a 15. As somebody's brain has taken a hit, they will go through a stage where they posture. And this is very common in the dying process. People posture. Usually we assess posturing by applying just a little tiny bit of painful stimuli. So what I will do is maybe very gently pinch a fingernail with my pin. I'll take the pin and just kind of pinch the fingernail. Just very minor, what's called painful stimuli. I like to do that because you can pinch a fingernail even if the family's all standing around the bedside. Don't be doing that sternal rub. You might have heard of a sternal rub where you're like real vigorously rubbing someone's sternum. That's an example of painful stimuli. Don't do it. It's unethical. And I've heard of people lose, paramedics and doctors losing their license for doing that. The family complained. It's disturbing to people, and you don't beat up your patients. But I will very gently just pinch a fingernail. And then decorticate posturing is when the hands twist and they'll come up like this. Decerebrate, their hands will twist outward, just like in the picture there. What's confusing is that most people, I would say, have a combination where one arm is decorticate and one arm is decerebrate. One of the problems with this is if you're posturing, you're FTD, you're fixing to die. But for the family, it always looks like purposeful movement to them. And so it becomes very hard for family to make the decision, for example, for organ transplantation, when they see their loved one moving. The decorticate and decerebrate posturing is always a very ominous sign. Not always, because the other patient that will sometimes do this is your epilepsy patient. The patients who are having seizures will sometimes posture while seizing. My stepsister, Chelsea, she lives at Mosaic, and she seizes constantly. And often it looks like a mixture of decorticate and decerebrate posturing, where one of her hands will come up like this and one of them will twist out like that. And then as soon as the seizure's done, she returns to normal. So for the most part, though, it's a pretty good indication that the brain is dying. Probably the worst type of traumatic brain injury is called diffuse axonal injury. And this usually happens with that coup contra coup injury where the brain is rattling around. And what we think is happening is a lot of the connections are just being severed. The brain connections are being severed. And so you'll have a patient who's completely, essentially brain dead. A lot of times with a diffuse axonal injury, they're essentially brain dead. Persistent coma. You got diffuse swelling, cerebral edema, bleeding in different places. And then final brain death, or the death of the individual cells, is when the calcium floods into those cells. Most people remain in a coma. And probably the most upsetting thing with diffuse axonal is you can't really see it very well. They're getting better. The MRI scans are getting better. But a lot of times you'll have a patient who's in a persistent vegetative state and we don't see anything on the MRI. So we say, and the family says, they're fine. Their brain is fine. But it's diffuse axonal. It's really a microscopic problem. Concussion, mild traumatic brain injury, they call it. But I think for us healthcare providers, the big thing is that we have to be vocal about this. We are the people out in the community. And if you do clinicals later at Madonna and you work on the TBI unit, you'll see the outcomes. It's tragic. Lots of stuff about concussions. If you can sort out in your brain the difference between the epidural, subarachnoid, and subdural bleed, that will serve you well. I would say the only real thing that you need to know is that this bleed, the epidural, is an arterial bleed. This is arterial. If you cut an artery in your arm, you can bleed to death very quickly. Same is true of the epidural hematoma. A very common place for this to happen is basically a punch to the side of the head. You get in a fist fight at the bar and you get punched on the side of your head, your temporal lobe. This temporal bone is one of the thinnest bones in your body. You fracture that bone, right underneath of it is a middle meningeal artery. You lacerate that, you've got an epidural hematoma. It's just a pleasant way of saying an arterial bleed in your skull. I worked in the ICU in Sioux City, Iowa, and I took care of a guy who was essentially brain dead, but he was a professional MMA fighter, mixed martial art. He was just screwing around with the buddy on the mats. They were warming up. He had a fight coming up in a few weeks, so they were warming up on the mats, and his friend just kind of elbowed him in the side of the head. Wasn't too hard, nothing like what you would have in a real fight, but he lacerated that middle meningeal artery, epidural hematoma. Test questions will always say severe headache. Worst headache of my life. Severe headache. And then symptoms of increased intracranial pressure. The best symptom, best predictor is decreased level of consciousness. The subdural is bleeding in the space below the dura mater, and this is the bridging veins. So this is a venous bleed. Your arteries, high pressure. Your veins, low pressure. So some people, a lot of people, I would say, can develop a subdural over about a week's time. Most commonly, the elderly in the nursing home when they fall. They fall and then they are perfectly fine. We do neuro checks for 2 days, 3 days. We're checking their pupils, paying all this attention to them. And then a week later, by that time we forgot that they even fell. A week later, now they have decreased level of consciousness. That's a subdural, it's a venous bleed. So epidural, arterial, they're gonna die very quickly. Epidural hematoma needs a neurosurgeon. The subdural, they might be okay. They might be okay. We have a little more time. And then the subarachnoid, this also arterial. You can have a traumatic subarachnoid, but also then those brain aneurysms that rupture, the brain aneurysms. The worst headache of my life, thunderclap headache. And then they rapidly lose consciousness. Subarachnoid. So subarachnoid, epidural, arterial, subdural is a venous, low pressure bleed.